Welcome, Doctor.
Thank you so much for that wonderful introduction. I'm delighted to be here today to talk with everybody about understanding MDS mutations and risk scores. I will be walking through the diagnosis of MDS today and also just a number of other entities with regard to mutation status. So we're going to refer to that as the impact of next generation sequencing, or the tool that we use in order to understand the mutation status of those patients with MDS. So we'll walk through some of those parameters. We're also going to talk about some of the prognostic scoring systems briefly for MDS and how it can assist in patient management. And finally, I will spend some time talking about the therapies for patients with low risk and higher risk MDS, and talk about some of the emerging therapies and ongoing studies that are promising. As many of you know, myelodysplastic syndrome affects about 15 to 25,000 patients a year. The median age is over the age of 60, and for most of the patients, they're over the age of 50. It does seem to affect more males than females, and we know that myelodysplastic syndrome is a multilineage hematopoietic progenitor clonal disorder, and we'll talk a little bit more about that. I know that's a mouthful. What we know about myelodysplastic syndrome is that there's ineffective hematopoiesis with subsequent peripheral cytopenias. And as a result of that, patients can present with different cytopenias or all types of cytopenias, whether it affects primarily the red blood cell line, the white blood cell line, or the platelet line. And so there's some heterogeneity that we see from patient to patient with regard to their individual presentation of MDS. We know that many of the patients that are diagnosed with MDS can succumb to infections or bleeding because of these cytopenias, and that there is a risk of transformation to AML in about 35 to 40% of patients with MDS. And we'll touch upon this towards the latter part of the discussion, but allotransplant is really the only curative option, and there are challenges that come with that, particularly because there are comorbidities and other issues in the older population that is diagnosed with MDS. I wanted to show a picture of what things look like in patients that have MDS, and trying to describe this to my patients, I describe the bone marrow as a factory, and the factory has to have production of cells, and these cells can be decreased in terms of production or quantity, but there can also be a quality issue with regard to the cells. And this picture is trying to show you the quality issues with regard to the cells looking funny, or what we call dysplastic. So in each of these figures, you can see a number of things that contribute to that dysplasia that's appreciated, whether the cells are too large, or whether they're not maturing appropriately, or if there's too many nuclei or center portions of the cells as compared to normal. And so I'll spare you all of the details by which our pathologists use to describe dysplasia, but obviously one of the major factors in having or classifying a patient with MDS is the fact that we're seeing the evidence of dysplasia in the cells. I wanted to highlight for you as well that as we talked about, the overall incidence of MDS is about 5 patients per 100,000. It is one of the most common myeloid neoplasms, and of course I make sure to talk with my patients that this is a cancer diagnosis. You can appreciate in the graph that demonstrates the SEER incidence rates, and you can see that the incidence of MDS increases with age. And in the orange bars, you can appreciate that it is affecting males more than females, but by and large, it is something that we follow and notice in patients that are older. The pathogenesis of MDS, it can be from 3 different portions. 1, because of increased DNA damage, 2, an immune dysfunction, and 3, because of epigenetic alterations. All of these can come together to lead to abnormal differentiation, where the cells are not maturing in the normal way and are associated with dysfunctional and dysplastic cellular proliferation. We know that there's altered apoptosis as a result of that, and what that means is that the cells are not having this normal cycle of growing and then dying, and they can perturb that cellular pathway. And finally, just like cells that need to grow, there needs to be a microenvironment that supports those cells in terms of growth. And we're learning more about the impact of the microenvironment and the signaling that's going on in that space that can alter the growth and contribute to the dysplasia that's appreciated in patients with MDS. Ultimately, many of these abnormalities are a result of stem cell dysfunction. And obviously, we've talked earlier about the fact that a bone marrow transplant is the only curative therapy at this point for patients with MDS. So we truly think that there's a driver in the stem cell that's leading to much of the pathogenesis of MDS. For those of you that have had to go through an evaluation for the diagnosis of MDS, you know that we look at the peripheral blood counts as well as reticulocyte counts that were discussed earlier by Dr. Patel and Dr. Masajewski. Patients undergo bone marrow biopsy and aspirate to look at the blasts, or the number of cancer cells in the bone marrow itself. We also look at cytogenetics or chromosome testing to help us determine if it's a higher risk or a lower risk MDS. Other tests that we look at are things that may be contributing to making the cells look dysplastic. And examples of that are nutritional things such as B12, iron, that if there's a deficiency of those features, then cells don't have the right nutrients to grow, and as a result can look dysplastic. And so it's important to rule out any kind of nutritional deficiencies to make sure that those aren't the driving factors to the dysplasia. I want to turn to some of those features that we use from the bone marrow biopsy and from the peripheral blood that really help us understand the risk in each individual patient that's presenting with MDS. Now, historically, we've used this international prognostic scoring system that was identified by Dr. Greenberg, and that was subsequently then revised to the IPSS-R. And here you see the variables that we use and the co-occurring scores that are attributed depending on each of those variables. So for example, if a patient has normal cytogenetics, that fits into a category of good risk. And so that patient is then given a score of 1 in the top line, as you see. Other parameters that we follow include the blast percentages, as well as the specific level from the peripheral blood with regard to the hemoglobin, the platelet number, and also the neutrophil count. One of the things that I've highlighted, of course, is the fact that the bone marrow blast being greater than 10% is one of the ways to get the highest number of points. And as a result, that can obviously increase the likelihood that a patient has a higher risk MDS. For those patients with each of those variables, we add up the scores that are associated with those variables, and that lands the patient into a specific risk score. And that risk score can be divided, obviously, as you see here, into lower risk and higher risk myelodysplastic syndrome. So you might understand that the prior IPSS scoring system was a little bit more simple than this approach, and it primarily just used cytogenetics, blast percentages, and if there were 1, 2, or 3 cell lines affected without the specific details in the numbers. But, you know, I think many of us want to have prognostic scoring systems that get better and better with time. And so what I'm going to talk about is the fact that there can be ways to improve this scoring system to help us understand which patients are at higher risk of progression to leukemia and which patients are at lower risk, and allow us to monitor and follow over time. So with that, I want to talk a little bit more about the fact that with these scoring systems, I just wanted to highlight and show you the picture that for the solid green line and the solid blue line, you see the lower risk patients with regard to survival, as well as their risk to transformation of AML. And the yellow line and the gray solid line, you see that that's representing the higher risk MDS patients with regard to survival and risk for transformation to AML. So I'm going to transition to talk a little bit about this molecular mutation profiling using next generation sequencing and how is this tool important. And I just walked you through the scoring system that we frequently use. And I'll jump to the fact that the next generation sequencing testing can help us even diagnose disease. And for some patients, we see the presence of these mutations just in age-related changes or age-related clonal hematopoiesis, something that we call ARCH. It can also be seen in patients that have clonal hematopoiesis of indeterminate potential, or CHIP. It can be seen in patients with MDS as well as AML. And I'll talk a little bit more about this in upcoming slides. This tool, if we are able to detect these mutations, can be used to follow those patients if they're being evaluated for progression over time. So it's really been an advancement in our field to better follow patients and help advise if we need to just continue following or if some intervention needs to happen. Other types of tools or benefits to using molecular mutation profiling not only includes the prognostic implications that I talked about earlier, and I'll talk and show you how it can have implications in terms of prognosis, but we can also use it as predictive tools. How are these mutations allowing us to identify which therapies patients may benefit from or not, and spare them exposure to therapies that may not be as beneficial to them. Furthermore, even after therapies, you can use this next generation sequencing to evaluate measurable residual disease to see if we have a good handle on the disease or if clonal emergence or regression is happening. Finally, some of the mutations that we see can be used as targeted tags, if you will, to invent drugs to target that particular mutation on the cell. And so there's a various number of targets and a number of novel therapies that are being used to help improve the outcomes for patients with myeloid malignancies. And I'll talk a little bit about some of them, but I won't spend all of the time today talking about that. I wanted to take a step back and just bring you back to where we started learning about some of the impact of somatic mutations. This is a study that was done by Jaiswal et al. Looking at patients that had heart disease. So this was part of the Framingham study where patients were actually followed over many, many years looking at the incidence of heart disease. They went back and took the blood from those patients that enrolled in that heart study and said, can we detect mutations in those patients? And if so, do they correlate with outcomes many years later? You can see that for the patients that were older, 70 to 79 versus 80 to 89 versus 90 to 108, there was an increasing likelihood of detecting these mutations. And the most frequent mutations that were seen were DNMT3A, TET2, and ASXL1. And I'll refer to these in the future as DTA mutations. You can also appreciate that the effect of these mutations on all-cause mortality, in particular for those patients over the age of 70, they found that there was an increased likelihood of hematologic malignancies by 11-fold, an increase of cardiovascular disease by 2-fold, and an increase of ischemic stroke by 2.6-fold. So this kind of led us to start thinking more about these molecular mutations and their impact in our health. You can see in this cartoon really trying to depict the incidence of these mutations by the different color circles in the cells. And you can see in the green bar, trying to reflect the clonal hematopoiesis of indeterminate potential, where you see the emergence of these mutations, but the impact on dysplasia or progression to MDS or AML really hasn't happened yet. And for many, many patients that have CHIP, really nothing happens and they don't have progression to MDS or AML as depicted in the top number of cells as you see that purple and that yellow circle. For others, there's clonal emergence that happens and that can progress to AML and then that can progress to MDS as well as to AML. So, as a result of much of the research that's been done in a multitude of places, I wanted to just demonstrate one study that was done by Hofferlock et al. Looking at over 900 patients diagnosed with MDS. And he found that there was in 90% of patients with MDS, there was at least 1 point mutation. And on average, there were 3 mutations per patient. By and large, most of these mutations were related to epigenetic machinery or spliceosomal machinery. And in the graph on the right, work by Raza et al. Really shows you those different cellular pathways that are affected by mutations. And some of them I want to highlight in terms of prognosis. And you can see that in the bottom axis, you have the median survival for patients. So for those patients with P53 mutations, which is the blue or teal ball in the bottom, those patients that have P53 mutations don't have as good a survival or outcome from their MDS compared to those patients that have an MDS that is mutated with SF3B1. And so we'll talk a little bit about what that means if we find those specific mutations in patients with MDS and how we might improve the outcomes for patients with them. Obviously, SF3B1 is of interest because we know that those patients do better. And so it would be ideal if we could have a good handle on why that is the case. But SF3B1 is an important mutation that really came into play because it's now actually used to help with the classification for patients with MDS. And so there's a specific entity now by the WHO defined as MDS with ring sideroblasts. And this can be seen with or without multilineage dysplasia. We know that there's a frequent association of mutations of SF3B1 and a favorable prognosis with low risk of transformation to AML. And in the WHO, the pathologists use specific criteria to identify patients with MDS and ring sideroblasts. They have to meet a specific criteria of greater than or equal to 15% rings or greater than or equal to 5% rings in the presence of an SF3B1 mutation. And so one of the things, obviously, that we'll talk about later on is that luspatercept is now FDA approved for patients with MDS and ring sideroblasts for which ESA-based therapy is no longer working. And so that was a very important and very exciting FDA approval that happened this year. And so we'll walk through some of the data that came from the PACE study and the other studies that led to that FDA approval. So how do these mutation profiles help us? I'll just recap that it can help us classify disease. Dr. Corey talked about this morning about somatic versus germline mutations. We know that mutations such as DDX41, ETV6, GATA2, and others, ASXL, other mutations in addition to DDX41, like RUNX1, also identified novel germline or inherited disorders that we need to think more about. Now, I'll highlight that that's the minority of patients, but this is a burgeoning field and really an area that I think we need to wrap our hands around more, and work done by Lucy Godley and others really are trying to better understand those profiles. Again, I'll highlight that SF3B1 is strongly associated with the presence of ring sideroblasts, as you saw in the prior slide, and it's more frequently seen in MDS with ring sideroblasts, about 80%. So not all patients with ring sideroblasts have an SF3B1 mutation, but the majority of patients do. And there can be other phenotypes that we see. So if SF3B1 and JAK2 are seen together in a patient, it's more often that we start worrying about the diagnosis of MDS, that's an overlap syndrome with MPN, ring sideroblasts, and thrombocytosis. And in that phenotype, patients often have an associated thrombocytosis. And for some of those patients, they can be exquisitely sensitive to the treatment with lenalidomide. And so those are features that we're starting to discern by the use of these tools. There are specific mutational patterns that also help us to identify specific phenotypes, such as chronic myelomonocytic leukemia, or even differences between secondary AML and de novo AML. Not only are there patterns, but we know that the impact of mutations on clinical outcome is important, as I've alluded to, with the differences of an SF3B1 mutation versus a TP53 mutation, as you see in the first graph to the left. We also know that the number of mutations has an impact in patients' overall survival, as well as leukemia-free survival, as work has been done on this from Dr. Behar and Dr. Papa-Emmanuel. So the higher number of mutations often is associated with a higher risk of myelodysplastic syndrome and a higher likelihood of progression to leukemia. Finally, we know, as I alluded to earlier with regard to the IPSSR scoring system, not only the number of genes, but specific genes in association with the presence of MDS can elevate the scoring risk for patients. Now, this hasn't been perfectly annotated and isn't a scoring system that's in place currently, but we know that if the patients have a mutation of TP53, ETD6, EZH2, RUNX1, or ASXL1, those patients actually can have an outcome that's similar to a higher risk IPSS scoring system. And so let's just walk through the first graph on the left. In the solid black line, you see low risk MDS patients. In the solid green line, you see intermediate 1 risk MDS patients. And in the hashed black line, you see those patients with low risk IPSS that have any one of those 5 mutations positive. And you can appreciate that the overall survival for those patients with a mutation present mirrors the outcome for patients with an intermediate 1 risk. So it increases the risk scoring for that patient, and hence we're able to kind of better advise that patient with regard to risk of their disease progression. And so that holds true for patients with low risk, intermediate 1 risk, and intermediate 2 risk, as depicted by the advancing graphs in the slide. We know that mutation of one of these 5 genes is independently associated with a decreased overall survival. And so these types of tools are really helping us to better inform our patients and to better inform our decisions about treatment. With regard to that, work by Behar et al. Had also looked at overall survival for patients in the post-transplant setting by mutation status. And here they looked at 87 patients with MDS that were evaluated for 40 genes in a retrospective study. 92% of the patients had mutations. When they went back to look, the presence of a TP53 mutation in the yellow solid line, you can see that overall survival for those patients was really poor compared to patients that had no mutation of TET2, DNMT3A, or P53 in the solid red line. And then obviously you see the differences with the solid gray and the solid blue line as well. So I'm going to transition now to some of the algorithms that we use and the treatments that we use for patients with lower risk versus higher risk MDS. Most of our patients with lower risk MDS have issues with anemia, but really our treatment goals in patients with MDS are to cure the disease, to improve overall survival, to lower the risk of transformation to AML, to pursue goals of complete remission, partial remission, or stabilization of disease. And finally, to improve trilineage hematopoiesis and function, to decrease infections, and to decrease transfusion support. And finally, we often want to decrease symptoms that impair quality of life. For those patients that have lower risk MDS, there's a gamut of things from observation to watch and wait, supportive transfusions, iron chelation, the use of growth factors to stimulate normal growth of cellular proliferation, and even the use of immunosuppressive therapy and immunomodulatory therapy. So I'm going to escalate and go kind of quickly through this because I know that many of you probably already are aware of these features. Supportive care for patients using antimicrobials if they're neutropenic can be impactful and helpful, as well as making sure that patients are updated with their vaccinations, such as the flu shot and even their pneumovax. The other supportive care that is often given is the support with red blood cell transfusions and even platelet transfusions. And for some patients that have greater than 100 units of packed red blood cells in their lifetime, we think about iron chelation. Iron chelation studies really suggest that iron chelation in lower risk MDS patients can improve survival and transfusion dependence. And there's a specific ferritin goal that we typically try to aim for by monitoring it. Patients, if they're getting that type of therapy, typically can undergo annual hearing and visual testing. And there are a number of options with regard to chelation therapy that are considered, but also importantly can impact quality of life because there are toxicities with these therapies as well. So there's a risk-benefit ratio that is often discussed. Other modalities really target the fact that patients struggle with anemia and the resulting symptoms that result from anemia in the majority of our patients with MDS. Transfusions can help, but are limited to some degree because of iron overload, fluid overload, and even the production of antibodies. Recombinant EPO is FDA approved for treating anemia associated with kidney failure, and ESAs have been used since about the 1990s in patients with MDS. The response rates with regard to ESA-based therapy range between 15 to 40%, and many studies have been done using these agents, so they're safe. We do have specific tools that we can use to identify those patients that are more likely to respond to ESA-based therapy. And more often than not, those patients that have a low EPO level and a low transfusion burden are more likely to respond to ESA-based therapy. And algorithms such as this one are really the issues that I'm talking about with regard to lower number of EPO, lower EPO level, and lower number of transfusions that are required, and we can tabulate a score as you see here, and then advise appropriately. So in summary, with regard to ESA-based therapy, many patients are not able to really start this therapy unless the hemoglobin is less than 10. Otherwise, there's issues with insurance coverage. For patients that begin ESA-based therapy, it's advised that we stop after about 12 to 16 weeks if the hemoglobin is not improved. And the use of these drugs can alter what we see under the microscope with a bone marrow biopsy. So it's often advised to kind of hold this therapy for about a month prior to the next bone marrow biopsy. And for those patients with ring sideroblasts, it can be used in combination with G-CSF with the thought that it will boost up the EPO, the erythroid response. We also do not appreciate that there's an increase in transformation to AML with the use of ESA-based therapy. Other types of modalities include immunosuppressive therapy. So ATG plus CSA is most active in patients with MDS that have a diagnosis of MDS associated with a bone marrow hypoplasia, normal karyotype, low-risk disease, and evidence of a PNH clone by flow. And there's some thought that even being HLA-DR15, having that being positive, you're more likely to respond to immunosuppressive therapy. And the types of therapy, whether it's horse or rabbit ATG, have been shown to be feasible and active. We know that ineffective erythropoiesis is the hallmark of MDS, and it arises in part from an intrinsic impairment of the EPO receptor signaling. And so treatment with the EPO ESA-based therapy it helps some patients, but not all. And so we need to find other modalities to help with this ineffective erythropoiesis. And one study that was done by Valeria Santini et al. Looked at the use of lenalidomide and found that it improved erythropoiesis in about 25% of low-risk transfusion-dependent MDS patients with a non-del(5q. And the improvement duration was about 7.75 months with the use of this oral lenalidomide medication. We know, however, that there is a poor response to ESA-based therapy in patients with del(5q. And, we're specifically talking about patients with del(5q because I'm going to be talking about lenalidomide. So we know if we use an ESA, if a patient has a del(5q, it's not that they can't respond. You see here that the response rate for del(5q is 48% versus non-del(5q to ESA 64%. But the duration of that benefit is less in those patients that have a del(5q compared to those with non-del(5q. So in that particular patient, what would we then turn to? And so, as you know, lenalidomide is an option for those patients with deletion 5q. And we know that the duration of transfusion independence for patients with lenalidomide is beneficial, as shown here. And the median hemoglobin increase was 3.2, and the time to response was about 1 month. There were some practical issues with the use of lenalidomide, following their blood count, which we often do in patients with MDS, and occasional dose adjustments that are needed for cytopenias. There has been work combining lenalidomide with ESA-based therapy, and some of that work was presented at last year's ASH by Alan List. And so some of that work, I think, is really important to keep in mind, particularly if people or patients don't have a response to single-agent len or single-agent EPO. What are some of the mutations that we know to help inform us? We know that the presence of 2 or more mutations are inversely related to a erythroid hematologic improvement in those patients that are on lenalidomide. And we also know that the presence of splicing factor mutations are inversely related to an erythroid hematologic response. So these are, again, clues that help us to pick and choose who might benefit from what therapy and how to better steer to one therapy versus another. I want to turn quickly to the use of luspatercept. As you all know, this is an investigational first-in-class erythroid maturation agent that neutralizes select TGF-beta superfamily ligands to inhibit the SMAD2 to 3 signaling and enhance late-stage erythropoiesis. And you will recall that in the prior talk by Dr. Masiszewski and Dr. Patel, they were talking about these reticulocytes, these baby red blood cells. And so this agent really helps that baby red blood cell to mature and become an effective erythroid cell. And so by that nature, this particular agent was studied in a phase 3 study called the MEDALIST study. And they enrolled patients with non-del(5q) MDS with ring sideroblasts that were EPO resistant or intolerant to ESA-based therapy or had an EPO level greater than 200. Patients were not allowed to have hypomethylating therapy prior to going on study, and patients were randomized 2-to-1 to receive luspatercept versus placebo. And as you see here, the primary endpoint was transfusion independence. And for those patients in the big blue bar, you see 47.7 patients achieved that, receiving luspatercept versus 15.8% for those patients receiving placebo. It was shown that the erythroid hematologic responses were durable, with about 40% of patients achieving transfusion independence that was sustained at 12 months of therapy. And so ultimately that led to the FDA approval, and now we know that luspatercept is an active agent for consideration. So when we think about the current algorithm for MDS, I'm now going to transition to talk about our higher risk patients with myelodysplastic syndrome. Kind of the backbone of therapy for these patients has really been azacitidine or decitabine-based therapy. Other options include lenalidomide, as we've talked about, or even intensive chemotherapy. Curative therapy really, though, means that patients are moving towards a bone marrow transplant. And the mainstay of therapy right now for patients with higher risk MDS is to really think about clinical trials, and specifically clinical trials that may be geared towards specific mutations that are found in the myelodysplastic syndrome patient. I put this up just because I want to remind everybody that transplant is really left for those patients that are diagnosed with intermediate 2 to high risk IPSS MDS. And you can see in the bottom graph for those patients, the benefit from transplant was better for those patients with high risk MDS compared to patients with low risk MDS. And in the top graph, you see those patients in the yellow line for low risk MDS, they did better without getting transplanted earlier because of the earlier onset of mortality that's incurred by going through such an intervention. So as you know, that allo transplant really offers long-term disease-free survival with patients with MDS, but not all patients that are able to go through a transplant actually survive or have 100% cure, because even in the post-transplant setting, we worry about MDS relapsing. There is also an issue or challenge that we have with the decreased ability to offer transplant due to comorbidities for patients. So those are all things to take into consideration with regard to risk-benefit ratio. We are advancing in our ability to offer transplants with reduced intensity transplants, haplotransplants, as well as core binding factor transplants. Again, we know that hypomethylating therapy is really the mainstay of therapy. This is a AZA-001 study led by Pierre Finot that really helped to establish and show that the use of azacitidine in the top line was compared to other modalities in terms of treating patients with MDS, whether it was low dose ARC, standard chemotherapy, or best supportive care. And in this study, there was an overall survival benefit for those patients that received azacitidine in the solid orange line compared to the dotted line in those patients that received conventional care regimens. And this was also this study was kind of recapitulated using decitabine. Unfortunately, the advantage in terms of overall survival was not shown, but that has not stopped the use of decitabine-based therapies or azacitidine-based therapies for patients with higher risk MDS. So both of these are acceptable modalities for patients that have higher risk MDS, either azacitidine or decitabine-based therapies. It is recommended to administer at least 4 to 6 cycles, and there are side effects and toxicities to these therapies that are manageable, but things that are important to be aware of, including GI toxicities, as well as myelosuppression or issues with low counts and needing transfusion support. In general, we want to make sure that if people embark on this type of therapy, that they stay on therapy for as long as they're tolerating it and as long as they're benefiting from it. It is recommended to do continuous dosing as long as patients are doing well and not to have long intermissions between one cycle and the next. For example, drug holidays are not recommended, as typically if it's held, then patients will have relapse of the disease and not respond as well when re-challenged with the same drug. We do recommend some bone marrow evaluations at least every 4 to 6 months to see, and now with some of the newer things that we'll talk about in the upcoming slides, maybe even sooner than that. So in general, we have to make sure to remind people responses are slow. They're often and can be associated with improved survival, particularly for patients that are responding to therapy. And moreover, even in my patients that are octogenarians and above, they are able to tolerate this therapy. And some of the data that was shown earlier really demonstrates this. Looking at least 87 patients, we can see that they were over the age of 75, and they too equally benefited from an improvement in overall survival with hypomethylating-based therapy. I will point out that there are data that show that patients that have a TET2 mutation are more likely to respond to a hypomethylating-based approach. We also know that there are some differences with regard to never responders to hypomethylating-based therapy versus partial or complete responders. And so for those patients that are responding, they typically are able to stay on therapy for greater than 6 months and continue to have stabilization of disease or some benefit. The never responders typically have received it for less than 6 months, and there may be lessons that we learn with regard to unique mechanisms of resistance, whether or not there's better or worse response to next in-line therapies, and concerns about maybe an increased expression of BCL2 or other resistance patterns or mechanisms. And that allows us to think more about combination therapies and how best to approach this particular patient population. So I'm going to turn very briefly to upcoming or newer therapies. Some that were presented at ASH in 2019 include agents such as roxadustat, which is a HIF-1 inhibitor and has been extensively studied in patients with end-stage renal disease and currently has an ongoing phase 3 study for patients with MDS that are transfusion dependent. Early responses or early reports of this drug looked promising, but we'll continue to follow. What's nice about this agent is that it's an oral agent and people don't have to come to the clinic to receive IV or sub-Q based therapy. There will be questions, and there has been a lot of interest in hypomethylating agents plus venetoclax, a BCL2 inhibitor, that kind of speaks to some of the mechanisms of resistance that I just alluded to in the prior slide, and I'll talk about that in the upcoming slides. Other hypomethylating agents that are important and have come to light include an agent called CC486. This agent was studied in the AZA-MDS-003 study. This study was closed early. It looked at patients with MDS versus placebo and who were treated with CC486 versus placebo, and that study was closed early due to a higher incidence of early fatal and or serious adverse reactions in patients who received CC486 once a day. The total number of patients in that study was 200, about 100 of whom received CC486 versus placebo. So another oral hypomethylating agent, though, that was recently approved is decitabine, sidazarine, or inaqovi, which is an oral tablet of decitabine that was FDA approved for adult patients with MDS that are previously treated and untreated de novo and secondary MDS patients. So the dose of this agent is 1 tablet daily, instructed to take on an empty stomach and given days 1 through 5 of each 28-day cycle. Other therapies that I think are on the horizon that are important to talk about is a p53 modulator called APR-246, as well as macroglib, which is a CD47 agent that we'll talk a little bit about. With regard to the TP53 mutation in patients with MDS and AML, this agent, APR-246, is a TP53 modulator. So in this blue little cell that you're seeing in the top left-hand corner, what happens is APR-246 will attach and reactivate that p53 mutation in the cell and allow p53 to be expressed and allow for cell cycle arrest and allow for that cell to then die. Which is, important in terms of getting rid of or eliminating the myelodysplastic syndrome or myeloid neoplasm abnormality. In the study led by Salman et al. As well as Cluzo et al., this data was reported at ASH in December of 2019. You can see that patients with both MDS, AML, as well as overlap syndromes were studied in this combination with APR-246 plus azacitidine. Overall response rates, you can see here 87, 88, and 75%, with a CR rate of 53%, 61%, and 50%. So this is a very exciting agent, really impressive responses in TP53 mutated myeloid disease in early studies. And as you recall, these patients with a P53 mutation have a pretty poor outcome. So having a promising agent for a really important patient population is very, very exciting. I promised you to talk a little bit about AZA and venetoclax for high-risk MDS patients. There was a data that was presented, a phase 1b study looking at patients with MDS and higher risk MDS not planning for intensive chemo or transplant, using azacitidine-based backbone and adding venetoclax, this oral BCL2 inhibitor, for 2 weeks' time. There were 57 patients that were studied, and you can see here that the complete response rate was 38.6%, the marrow CRs were 38.6%, and also the stable disease was 15.8%. So for these patients, this objective response rate was pretty impressive for combination therapy. The median time to complete remission was about 2 months, and the duration of response after CR was the 12-month estimate for those that had achieved a CR was 83.3%. So again, also a very promising study. You can see here the overall survival by patient response, depending on the complete response or marrow CR or other response here. Data was also presented by Dr. Zidane at ASH in 2019, as well as at EHA, further establishing that this combination was well tolerated in patients with higher risk and relapsed refractory MDS. Many of the adverse events were primarily hematologic toxicities with marrow suppression and need for transfusion support. And it really demonstrated promising clinical activity in the frontline therapy of those patients with response rates of upwards of 70% and complete response rates up in the 39% for patients with de novo frontline, and overall response rates of 41% and CR rates of 7% in those patients with relapsed refractory MDS. So currently there's a Verona study, which is a registration phase 3 of aza-ven in the frontline setting for higher risk MDS patients. And there's further need to define predictors of response and mechanisms of resistance. And the take-home points is exactly what I just walked through. Finally, with AZA plus macroglib, this is a phase 1 study that was also studied. It's a macrophage immune checkpoint and do not eat me signal in those patients with MDS, again studied in a cohort of about 35 patients. And here you can see complete response rates in some of those patients between 44 and 50%. The median overall survival was not reached in 5 patients, and patients were obviously also transitioned to receive an allo transplant because their disease was then controlled. So again, another new promising agent for higher risk MDS. The combination was well tolerated, and I think we're going to be seeing additional agents added to these backbone therapies. Whether those backbone therapies will be oral or IV remains to be seen, plus another agent to try and really target the profile that we see in each individual patient harboring MDS. Again, venetoclax is kind of a mutation agnostic because it can target many patients with a varying different mutational profiles. So that is also equally exciting and something that I didn't mention in the prior slides. With that, I want to recap that and remind you that hypomethylating therapy is really the mainstay of therapy for patients with a higher risk MDS. This type of therapy is not curative nor durable, and the duration of hypomethylating therapy should last at least 4 to 6 months unless there's obvious intolerable toxicity or progression of disease. There are new oral medications that are approved for MDS in the last year, which is very, very exciting. And again, just to remind you that molecular mutation profiles can help us to understand the clonal evolution of the disease and the risks and the risk profile for each individual patient. And I just want to underscore the importance of clinical trials at every stage of MDS and these targeted agents and novel therapies and the investigations that are ongoing to really change the face and the outcome and improve things for patients that are diagnosed with MDS. And with that, I want to thank you for your attention, and I'm happy to take questions.
Thank you, Dr. Carraway. We have a couple of questions. Our first question is regarding to age of patient. They'd like to know, is there an age requirement to be in a clinical program, and is age 88 too old for medication to be given to a patient with MDS?
So I love this question. I really think that it is important to include all patients with a diagnosis of MDS, irrespective of age. But this question is highlighting the fact that many of the studies will exclude patients, whether younger or even older. But by and large, we try very hard now to not exclude patients based on their age. Many of the exclusion criteria are based off of kidney function or liver function, or even performance status with regard to the ability to get up and move around. But by and large, most patients that are interested in clinical trials, each trial may have different eligibility criteria. And I would encourage you to reach out for looking for those options, and being 88 years old will often not exclude patients from clinical trials. And I think that's a very important area for us to continue to investigate.
Thank you.
Second part to that question. I hope I answered it. I can't.
You did.
Okay.
Is there a connection between hairy cell leukemia and MDS?
It is not all that common for patients to have co-occurring hairy cell leukemia and myelodysplastic syndrome. It can be that patients that have hairy cell leukemia have been treated with intensive chemotherapy. That may or may not be true. And if true, then it can lead, that intensive chemotherapy can lead to an acquired or secondary myelodysplastic syndrome. It can be a little challenging, and I alluded to this earlier, that in patients that present with cytopenias, we have to rule out other things that are contributing to those cytopenias, whether they're nutritional or whether they're co-occurring issues, such as hairy cell leukemia, which is also known to cause cytopenias. There are other entities such as MGUS that occur in about 20 to 30% of patients with MDS. I've had a number of patients that have had overlap syndromes, not just of MDS, but along with PNH or even LGL. So it is important to evaluate for co-occurring issues. LGL, PNH, MDS, hairy cell leukemia, all of these are rare entities, and having them together in one patient, I won't say never, but it's pretty, it happens probably in maybe 10 to 20% of patients. Although I personally have never seen a patient with both MDS and hairy cell leukemia, but if it happens, I think it's probably uncommon.
Sorry, our next question is there currently an FDA-approved treatment for patients with TP53 mutation?
So currently for patients with P53 mutated MDS, we are encouraging those patients to go on to clinical trials. Currently, the therapy that we often use for patients with higher risk MDS, such as MDS with TP53, the FDA-approved agents would be agents like azacitidine and moving towards transplant. The hope is that this specific, and I think this question is specific to agents like APR 246, that is not FDA approved at this time. So I don't know if that question is geared towards that, but for patients, there are clinical studies, as I alluded to.
Thank you. And our last question is, are there any new studies for low-risk patients with the TET2 mutations?
Just to recap, additionally, those patients that have ability to receive AZA-based therapy, those are really the directions currently that we're using for patients, whether they're TET2 mutated or P53 mutated. Some of the question that just arose with regard to TET2 mutations, there's ongoing studies even at our institution incorporating the use of vitamin C in combination with hypomethylating therapy, with the thought that that would actually improve the response to hypomethylating therapy. Again, that's not an FDA approved, that's currently under clinical investigation. So I think at this point, that's where I would guide people to look.
Thank you so much, Dr. Carraway, for spending your time with us today and sharing your expertise with all of us. If you would like to watch this session again at a later time, it will be available on our website within 2 to 3 business days. If you have any additional questions, you can send it to us in 3 ways. Send an email to help@aamds.org, call our helpline at 800-747-2820, extension 2, or submit your question on our Facebook page. This conference session will end, and to rejoin the next session, please use the same Zoom link or call in using the same phone number provided in your conference registration email. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and making us your resource of choice on bone marrow failure diseases. The AAMDS-IF Medical Advisory Board and team are here to support you and your family as we have done for the past 36 years. This concludes our session. Thank you, Dr. Carraway. Have a good day.
You too. Thank you very much for the opportunity.